Welcome back to CMS Prep. As I had promised in the last video that we are going to cover all the questions related to surgery from 2009 to 2024 chapter wise and topic wise. The first topic that we will be starting is hernia. So what is the trend of the questions that are being asked in the hernia? So as you can see in this beautiful graph, I have depicted all the various types of all the questions that have been asked from hernia from 2009 till 2024. As you can see in this graph that the number of questions are varying in between from 1 question to 5 questions, and the maximum number of questions that were being asked were in 2017 till 2022, after which the graph has again plateaued again. Within hernia, what are the various different topics in which questions are being asked? So for that I have classified the topic into definition, anatomy, classification, etiology, pathophysiology, clinical feature, management and case scenarios. So in this you can see that the maximum number of questions that are being asked from the topic of hernia is from the management or the surgery point of view. So now coming to the summary, if you are guys preparing for UPSC CMS, you can see 28 questions have been asked in the previous 16 years. 4 questions can be expected from this topic, focusing mainly on the management aspect of hernia. So if you are preparing, kindly prepare the surgery part very well, because many questions are being asked from this topic. So now let us move onward and discuss all the questions related to hernia. So the first question is, when the hernia extends between the layer of abdominal wall muscle and not directly through them, it is called. So the correct answer is Spigelian hernia. Why others are incorrect? In Richter's hernia, this involves only a part of bowel bulging through the hernia and not between the muscle layer. Amiand's hernia, the appendix is a part of hernia, usually in the inguinal canal and not between the abdominal layers. And in Litter's hernia, the content is Meckel diverticulum. So this contains a Meckel diverticulum which is unrelated to the abdominal wall layer. Spigelian hernia is the correct answer because they are unique, because they occur in between the abdominal wall muscle rather than directly through them. So the correct answer for this is Spigelian hernia. Now moving on to the next question. The following nerves are blocked for repairing inguinal hernia by local anesthetic except. So this is a pretty straightforward questions. You have the options: ilioinguinal nerve, iliohypogastric nerve, genitofemoral nerve and femoral nerve. So the correct answer is femoral nerve. Femoral nerve is not blocked for repairing inguinal hernia. Rest 3 nerves are blocked. Why? Ilioinguinal hernia, ilioinguinal nerve. So this nerve provides the sensation to the inguinal region and is routinely blocked for inguinal hernia repair. Iliohypogastric nerve, this nerve supplies the lower wall of the abdomen and it is also commonly blocked in hernia repair. Genitofemoral branch, see the genitofemoral branch has genitofemoral nerve has 2 branches. It has the genital branch and the femoral branch. The genital branch supplies the scrotum and the groin area, so it is blocked as a part of procedure. Therefore the correct answer is femoral nerve. Femoral nerve is not blocked in the by local anesthesia for treating inguinal hernia. Now let's move on to the next topic. The next question is, all are rare type of lateral hernia of abdominal wall except. So this question is basically asking you which of the following is not a type of lateral hernia. So if you guys remember, the superior lumbar and inferior lumbar, they occur on the back side and definitely and on the flanks, so they are part of lateral hernia. Spigelian hernia is a true lateral hernia which occurs intra-abdominally and occurring along the Spigelian face. So the odd one out here is obturator hernia. So obturator hernia is not a lateral hernia, it occurs through the obturator canal in the pelvic region. So this is pretty simple question. Now let's move on to the next question is, ventral hernia includes all except. So in this you are being asked which of the following is not an example of ventral hernia. So epigastric hernia is a type of ventral hernia, paraumbilical hernia is a type of ventral hernia, lumbar hernia is a type of ventral hernia, but inguinal hernia which occurs in the inguinal canal is not a type of ventral hernia. This is also pretty easy question. It occurs in the groin area all of these occur in the ventral wall, so and this one occurs in the posterior wall. So these are the type of ventral hernias except inguinal hernia. What is the most common hernia in females? So see, this is a pretty tricky question. You guys might have heard that you might have read that femoral hernia are more common in female. This is a true statement, but if you see total number of cases, out of those cases the maximum cases are of inguinal hernia. So don't get tricked into this type of question, guys. Femoral hernia is more common in female than in males, but in females the overall most common hernia is definitely going to be inguinal hernia. Okay, so let me summarize this. Inguinal hernia is most common in both male and female, though the incidence in female is lesser. Femoral hernia more common in female than male, but still less common than inguinal hernia. Spigelian hernia, it is a rare type of hernia which is not common in either gender. And obturator hernia, it is extremely rare, which is generally seen in elderly and malnourished female. Which of the following factors predispose to the development of incisional hernia? You know what is incisional hernia? So if you had a surgery prior and there is some outpouching from the site of the incision, then it is known as incisional hernia. So in this question it is being asked that which of the following factors predispose to the incisional hernia. So let's read the options. What is being asked? The first one is malnutrition, second is post-operative wound infection, third one is non-absorbable suture material, fourth one is immunocompromised patient, and you have to select in between these four options. So basically what happens is that malnutrition weakens the abdominal wall and it is definitely going to increase the risk. Post-operative wound infection causes poor healing and it increases the risk for incisional hernia. Immunocompromised patient. Immunocompromised patient presents with delayed healing and weakened tissue integrity, which predisposes him or her to the hernia. Now coming on to this option, which is doubtful, non-absorbable suture material. While non-absorbable suture material might cause discomfort, it does not directly predispose to incisional hernia formation. Therefore, the correct option is 1, 2 and 4. Femoral hernia is more common in female because, now UPSC is trying to ask us, why does femoral hernia occur more in female? And if you read the option, it will confuse you. The first option is femoral canal is long. The second option is femoral canal is wide. The third option is ligaments of femoral canal and neck are weak. And the fourth option is weakness of posterior inguinal wall. So the correct answer is femoral canal is wide in female. In female, the wider pelvic structure creates a larger and wider femoral canal, making the femoral hernias more common. The length of femoral hernia is not a significant factor, and there is no evidence that ligaments of femoral canal are weak in females, and weakness of posterior inguinal wall will lead to inguinal hernias and not femoral hernia. Therefore, the correct option is femoral canal is wide in female. In case of obstructed hernia, strangulation is suggested by which of the following features? The first option is presence of shock, pain is never completely absent, localized tenderness which is associated with rebound tenderness, pain persists despite conservative management, and an external hernia becomes tense, tender, irreducible with recent increase in size. So which of the following clinical features suggests that obstructed hernia is going under strangulation? So the correct option is all of the above, 1, 2, 3, 4 and 5. Why? Presence of shock. This indicates systemic effects of strangulation. Pain is never completely absent, and this suggests ischemia. Localized tenderness is associated with rebound tenderness. This indicates peritoneal irritation from ischemia or necrosis that is going on. Pain persists despite conservative management. This indicates that there is ongoing strangulation. And the last option, that is tense, tender and irreducible mass with recent increase in size. This is a hallmark feature of strangulated hernia. So the correct option is 1, 2, 3, 4 and 5. I'm sorry guys, this B option. All the options relate to strangulated hernia. Which of the following are features of umbilical hernia in adults? So the first option is patients are commonly overweight with a thinned and attenuated midline raphe. Most patients complain of pain due to tissue tension. Men are affected more commonly than women. Hernia repair can be done by the technique described by Mayo. Out of these statements, let's analyze them one by one. So patients are commonly overweight with thinned and attenuated midline raphe. This is a correct statement. Most patients complain of pain due to tissue tension. So this is also correct statement, as the stretching of tissue causes discomfort. Men are more affected than female. Friends, this statement is wrong. Men are not more commonly affected, but women, especially after multiple pregnancies, are more predisposed to umbilical hernia. And hernia repair can be done by the technique described by Mayo. Mayo's repair is a standard procedure for hernia repair in adults. So the correct option is 1, 2 and 4. Now let's move on to the questions that are being asked from the management domain of hernia. So in this, first we will discuss all the questions that are related to surgeries. Then we will move to the questions that are being asked from mesh and sutures, and then we will move to triangle of doom. So let's read the first question. The first question is, which one of the following is the treatment of choice in a child with inguinal hernia? This is a pretty straightforward answer. The correct answer is herniotomy alone. Herniotomy alone is the treatment of choice for inguinal hernia in children. This procedure involves the removing of the hernial sac, and it is a straightforward procedure suitable for children since their inguinal canal is small and they typically do not require mesh repairs. Bassini repair. This is a procedure in which the inguinal canal is repaired using sutures, and it is not typically used in children. Soldis repair. This is also a technique used in adults. It involves a tissue repair without a mesh. And the Lichtenstein repair. This involves a mesh placement to reinforce the abdominal wall. It is used in adults for hernia repair, but not necessarily for children, where a simple procedure like herniotomy is sufficient. So the correct option, or you might cram it like the treatment of choice for children with inguinal hernia is herniotomy. So this question is asked in various exams, so it is important. Now let's move on to this question. This question has been asked twice. See here, Swiss cheese defect and again Swiss cheese defect. So Swiss cheese defect of anterior abdominal wall after exploratory laparotomy is best seen while doing which type of surgery? So first of all, what is Swiss cheese defect? So Swiss cheese defects are small multiple hole in the anterior abdominal wall which can be seen while repairing a large hernia or complicated ventral hernia. These defects are often better visualized during laparoscopic ventral hernia repair because the laparoscopic technique provides a clear magnified view of the abdominal wall, making it easier to identify small hidden defects. So the correct option is laparoscopic ventral hernia repair. Now let's discuss about why other options are incorrect. So in open ventral hernia repair, while Swiss defects can be seen in open surgeries, the visualization is not as clear or magnified with laparoscopic technique. Open inguinal hernia repair, this type of hernia is located in the groin and not in the abdominal wall, so Swiss cheese defects are not typically seen during this procedure. Laparoscopic inguinal hernia repair. Inguinal hernia are in the groin area, not in the abdominal wall. So Swiss cheese defect do not apply there. So basically, when you are doing ventral hernia repair with laparoscopy, so you will find multiple small holes or defects in the anterior abdominal wall. These are known as Swiss cheese defects because they resemble the Swiss cheese. It is pretty straightforward, and this question has again been a bit twisted. The question is, Swiss cheese defects are seen during the laparoscopic repair of which type of hernia? So it is not seen in inguinal, obturator or femoral hernia, it is seen in ventral hernia. Now let's see question number 12. The question number 12 is, which of the following is not a tissue repair surgery for inguinal hernia repair? So basically you are repairing it with either tissue or a mesh. So let's review the options. The first option is Bassini's repair. So Bassini's repair is a tissue based repair that involve multiple layer of suture to strengthen the inguinal canal and prevent reoccurrence. Soldis repair is also a tissue based repair that involves layer of suture to strengthen the inguinal canal and prevent the recurrence. De Sarda's repair. De Sarda's repair is also a tissue based repair method where the muscle fascia is being used to reconstruct the inguinal canal without using a mesh. So the correct option is Stoppa's repair. What do we do in Stoppa's repair? Stoppa's repair is a mesh based technique. In this we are using basically mesh. It is not a tissue repair. It involves placing a mesh to reinforce the inguinal region and is typically used for large or recurrent hernias. Therefore it is not considered a tissue repair surgery. Let's move on to the next question, which is this one. This is one liner and very easy. Mayo's repair is done for. The correct option is incisional hernia. Mayo's repair is a surgical technique used for the repair of incisional hernia which occur at the site of previous surgical incision. The procedure involves suturing the edges of the defect together, often with reinforced technique to strengthen the area. Inguinal hernia can be repaired with Bassini's or Soldi's repair, not Mayo's repair. Femoral hernia is typically repaired using McVeigh's repair, other types of procedures, but not using Mayo's repair. Umbilical hernia are repaired with variety of methods, but Mayo's repair is typically not used for them. Technique like simple closure or mesh repair is performed for umbilical hernia. So the left out option, or you might want to cram it once again, that Mayo's repair is done for incisional hernia. Now let's move on to the next question. The next question is, which of the following is not a surgical modality for treatment of femoral hernia? So the correct option is option number D, that is canal ring narrowing operation or Lytle's operation. Lytle's operation is not used for femoral hernia, it is more related to inguinal hernia. Now let's see why other options are correct. The first one is Lotheson's operation. This is a surgical technique used to repair the femoral hernia by reinforcing the posterior wall of the femoral canal. The high approach and the low approach. The high approach is known as McVeigh's repair and the low approach is known as Lockwood's repair. So the high approach, this approach involves accessing the femoral hernia through the lower abdomen and is a standard technique for femoral hernia repair. While the Lockwood procedure approaches the femoral hernia through the thigh and is also used in repair of the femoral hernia. So the correct option is D. It is Lytle's operations is used in treatment of inguinal hernia, not of femoral hernia. Now let's move on to the next question. Which of the following are tension-free inguinal hernia repair? So tension-free inguinal hernia repair involve the usage of mesh. So first of all, why we are using mesh? So the mesh is used to cover the hernia, which reduces the tension on the surrounding tissue and also reduces the risk of recurrence. So basically we use mesh for two things. The first one is using the mesh to reduce the tension, and the second one is using the mesh to reduce the recurrence. So in the following question there are four options. The first one is Topaz repair, second one is Lichtenstein repair, the third one is laparoscopic total extraperitoneal repair, and the fourth one is Disarda's repair. So the correct option in this question is 1, 2 and 3. So first of all, Topaz repair. Topaz repair, this is a tension free repair using mesh which is placed behind the abdominal wall to cover the defect. In Lichtenstein, it is a widely used tension free technique where the mesh is placed to reinforce the inguinal canal. And in laparoscopic tap repair, it involves inserting a mesh through a minimally invasive laparoscopic approach to repair the hernia, creating a tension free environment. Now coming to Disarda's repair. In Disarda's repair, it is not a tension free repair. So because in this we are using patient's own tissue to reinforce the inguinal canal. So basically we are using fascia of patient's own body to reinforce the inguinal canal, which creates tension at the site of repair. So above three, that is Topaz, Lichtenstein and TEP, are tension free repair. Now let's move on to the questions that are asked on mesh and sutures. So the first question is, in hernia repair, polypropylene suture is used because. So first of all, you need to know about properties of suture. So in any suture you need to know three things. The first one, whether it is natural or synthetic. The second one is that it is monofilament or polyfilament, and the third one is whether it is absorbable or not absorbable. Okay, so according to this, the polypropylene suture is a synthetic monofilament and non-absorbable suture. So let us find which option is depicting it correctly. The option number B, synthetic, monofilament and non-absorbable suture. Dyed, it is also dyed. So why it is dyed? It is dyed for visibility during the surgery, and it also has low tissue reaction and high tensile strength. Therefore polypropylene suture is used. Now let's review other options. It is a synthetic braided dye. Sorry, this is not the correct option. It is a synthetic monofilament undyed. Sorry, it is a dyed suture. And the last option is, it is synthetic monofilament undyed. This is also wrong. Non-absorbable is correct. Here absorbable is also correct, wrong. Which has high tissue reaction. Sorry, it does not has high tissue reaction, it has low tissue reaction, and it does not degrades. So this is also not the correct description of polypropylene suture. Therefore the correct option is option number B. It is a synthetic monofilament dyed non-absorbable suture with low tissue reaction and high tensile strength. Now let's move on to our next question. Which of the following regarding absorbable meshes is not true? The first option is, they are made of polyglycolic acid fiber. It is a correct option. They are used in temporary abdominal wall closure. They are used to buttress suture repair. They show very good result as collagen deposition is maximum. So this option is not correct. So why it is not correct? Because absorbable meshes are designed to dissolve over time and support healing during the early phase of surgery. However, they do not show the best collagen deposition as compared to permanent meshes. So permanent meshes show greater collagen deposition in compared to temporary meshes. Option number B, absorbable meshes are commonly used in temporary wall closure as they provide support until the tissue heals. So this option is correct, and they are used to buttress suture repair, providing temporary reinforcement during the healing process. So this option is also correct. The option number D is incorrect. Now let's move on to our next question. Which of the following type of meshes is recommended for intraperitoneal use in abdominal wall hernia? So the options are lightweight porous mesh, heavyweight porous mesh, absorbable mesh and tissue separating mesh. So the correct option is option number A. We need lightweight and porous mesh. So lightweight porous mesh are most recommended for intraperitoneal use in abdominal hernia repair because they allow for greater tissue integration and they reduce the risk of complications like adhesion, which are more likely with heavier and less porous mesh. Heavyweight and porous mesh are not ideal for intraperitoneal use due to higher risk of adhesion and other complications. Absorbable mesh, the story with this is that while absorbable mesh can be used in certain situations, they are not typically the first choice for intraperitoneal repair due to their temporary nature. So this is the main disadvantage, and tissue separating mesh is a different thing altogether. So these are not typically used for intraperitoneal hernia repair, and their primary role is different from that of standard mesh that is used in abdominal hernia repair. Okay, so now let's move on to our next subtopic, that is triangle of doom. So from triangle of doom, 3 questions have been asked. So first let me discuss what triangle of doom basically is. Triangle of doom is a structure which is visualized during laparoscopic surgery. This is the deep ring, and here is your external iliac artery and external iliac vein. Now this is called as triangle of doom because damage to these structures would mean a lot of bleeding and the patient might die. So the boundaries of this triangle is inferiorly it is bound by the peritoneal fold. So this is the peritoneal fold. Laterally it is bound by the gonadal vessels, and medially it is bound by the vas deferens or the round ligament in females. So if you know the boundaries, you can easily crack all of the questions that have been asked. So let's see this question. The question is saying that during the laparoscopic inguinal hernia repair, in the triangle of doom, the following structures are. So in this question it is basically asking about the boundaries of triangle of doom. So vas deferens is on the medial side, this is correct option. Cord structures are on the lateral side, yes, I think so. Base is formed by iliac vessel, this is the wrong one out. And it is a dangerous area for dissection, yes, this is also correct because it contains external iliac artery and vein, and damage to this can be critical. Next question, question number 21. Triangle of doom is dissected and seen during laparoscopic inguinal hernia repair, is bounded by all except. So in this question again they are asking for the boundary of triangle of doom. So vas deferens is the medial boundary, cord structures form the lateral boundary, peritoneal folds form the inferior boundary, and the inferior epigastric artery is the odd one out. Inferior epigastric artery forms the boundary for Hasselbalch triangle. It does not forms the boundary for triangle of doom. So this is the correct answer. Now moving on to the next question. Structures not forming the triangle of doom seen during laparoscopic inguinal hernia surgery dissection is. So in this question again they are asking for the boundaries of triangle of doom. So vas deferens forms the medial border, spermatic cord vessels form the lateral border, and the peritoneal fold forms the base of it. So again the odd one out is inferior epigastric artery. So if you know the anatomy of triangle of doom and its significance, you can easily solve these 3 questions. Now let us move on to our next topic, and that is case scenarios. So question number 20. A young sports person presented in surgical emergency with the complaint of severe pain in the groin area extending into the scrotum and upper thigh. The pain is debilitating and he is not able to exercise. On examination there is tenderness in the region of inguinal canal and pubic tubercle. He is probably suffering from. So in this question we have a young sports person who presents in surgical emergency with severe pain, and that is extending into the scrotum and upper thigh, and he is not able to exercise, and there is presence of tenderness in the inguinal region in the pubic tubercle. So the correct answer is sportsman hernia. Why other options are incorrect? Let's go through them one by one. So first of all, let's discuss about sportsman hernia. Sportsman hernia is characterized by groin pain, and it is often seen in athletes due to strain in the muscle and the tendons of lower abdomen and pelvis. The pain can radiate to the scrotum and upper thigh, and it is often aggravated by exercise. Now, why is varicocele not the answer? This involves the swelling of the veins of the scrotum, which usually present as painless mass and not with groin pain and exercise related symptoms. So this cannot be our answer. Inguinal hernia can cause pain in the groin, and pain is typically related to the hernia's presence or incarceration. It is not related to exercise, so this one is also ruled out. And femoral hernia usually presents with a bulge in the upper thigh or the groin, and but the symptoms are more typical of a sportsman hernia, and this one is also ruled out. Hence the correct answer is sportsman hernia. Now let's move on to the next question. A 35-year-old female had laparoscopic ventral hernia repair using polypropylene mesh in January 2015. In June 2015, she is admitted again with the feature of subacute intestinal obstruction and is managed conservatively. She continues to have recurrent colicky pain. Most probably she is suffering from. So what do you guys think? What is the correct answer? So the correct answer is bowel adhesion to the mesh. After the repair of the hernia, adhesions are a common complication, leading to recurrent pain and subacute obstruction along with colicky pain. Recurrence of hernia, this would typically present with a palpable bulge, but the patient is having symptom related to bowel obstruction, so this is less likely of a recurrence. New hernia, while a new hernia can form, but this would not be associated with the symptoms like intestinal obstruction or recurrent colicky pain. Acute appendicitis, now this one can be confused, but this typically presents with the pain in right lower quadrant pain, and associated with fever and nausea, not with recurrent colicky pain and obstruction. So this one is ruled out on the basis of symptoms. So the correct answer is bowel adhesion to the mesh. So question number 26. A 5-year-old male child comes with a left side scrotal swelling which has no cough impulse and does not reduce on compression or lying down, but the parents give a definite history that the swelling is absent in the morning and comes by in the evening. So what is the best treatment that can be advised? See, there is no cough impulse, so it reduces the chance, or it rules out inguinal hernia. There is the swelling is absent in the morning but comes by in the evening, which is suggestive of fluid that is pooling in due to gravity, and the swelling does not reduce on lying down or compression, so it suggests that it is not reducible, further differentiating it from a hernia. And a 5-year-old male, here the age is also important, which suggests that it can be a hydrocele, because in children it is common due to patent process vaginalis. So the best treatment is eversion of sac. So this is the best treatment, and this is the correct option. To leave it alone, masterly inactivity, it is also correct, but conservative management of children is generally done under 1 or 2 years, and observation is preferred, as spontaneous closure of processes vaginalis often occurs. However, if it does not occur, then the only treatment of choice is eversion of sac. So herniotomy and hernioplasty are related to hernia surgery, which is not the case here. Here it is the case of hydrocele. A 20-year-old patient underwent open hernia surgery 4 days back. He is running fever for the last 1 day, and on local examination the operated site was wet with pus and surrounding redness and edema. The appropriate management would be. So all these options seem correct, but we have to choose the correct one. Change of antibiotics, daily dressing, opening suture and cleaning the wound, and sending the pus for culture and sensitivity examination. So the correct option is opening sutures and cleaning the wound. See, the symptoms which are described, such as fever, redness and swelling and pus at the surgical site, suggest wound infection. So the best initial management is to open the wound and clean it and drain the pus to prevent any further infection. Change of antibiotics, it would be considered after the wound drainage, not the initial best step. Daily dressing, while daily dressing are important, cleaning and draining the wound currently is more urgent to prevent complication. Sending the pus for culture and sensitivity. This can be done after the wound drainage to guide antibiotic therapy, but the first step is to address the infection, and that is opening the suture and cleaning the wound. So this is the correct answer. Now let's move on to our last question, and the last question is: a 40-year-old man with a history of reducible left groin swelling of 2 years come with a pain over left groin. The swelling is now irreducible and very tender to touch. The most probable treatment plan for this patient would be. Now there was a reducible swelling which after 2 years has become irreducible, and it is associated with extreme tenderness. So what do you guys think? It is a case of incarcerated or strangulated hernia, which is an emergency condition, and it requires the patient to undergo emergency surgery to avoid complication like bowel ischemia or perforation. So this is the correct answer. Why other options are incorrect? Because continuing the conservative management is inappropriate with symptoms suggesting incarceration or strangulation. Hot fermentation of the groin area. This will not address the underlying hernia problem and can delay the appropriate treatment. Oral antibiotics. Oral antibiotics is not appropriate for strangulated hernia, which requires surgical intervention. So the correct option is preparing the patient for emergency surgeries. So guys, with this we have completed hernia, covering all the 28 questions that were asked in the previous years, covering from 2009 till 2024. Kindly like, comment, subscribe and follow our channel. More such videos related to UPSC CMS are coming soon. Now for the notes and the answer with explanation, you can follow our channel, that is CMS Prep, on Telegram. There we will upload the PDF along with the answer key. So guys, keep preparing and all the best. Thank you. Meet you in the next video.